And I'm excited to talk about C. diff and prevention. So last year I got to talk about C. difficile infection as well. But however, last year I focused a lot on antibiotic usage for C. diff and our new guidelines. But this year our objectives is how do you clean environmentally appropriate cleaning process in our hospital system, monitoring methods in our hospital system for how do we do a good job cleaning our rooms, also isolation and hand hygiene, and a little bit about reducing unnecessary antibiotic in long-term care and how can we reduce C. diff in those terms. So please feel free to ask questions. So just a little background on C. diff. In 2015, we had over 500,000 cases of C. diff around US. About $15,000 deaths due to C. diff, and making it one of the highest reasons for having death due to hospital-acquired infections. So this is data from for Nebraska. It's hospital-acquired infection rates. And if you can see, since 2015 to 2017, our ratio for C. diff has been around 0.8. When you look at CDC NHSN, ideally you want your C. diff rate to be less than 1. So as Nebraska, we're doing as a whole good job. We're staying below 1, but we're still at 0.8 SIR rate. So we have a lot of opportunity to bring this down. Ideally, we should be at 0, but hope is to bring that rate down. So what are other opportunities we could do to do that? So in 2016 and 2017, compared to nationally in acute care facilities, we had over 13% decrease in C. diff rates compared to other states and nationally. So which is great, but we still have a lot more way to go. So what are the risk factors for C. diff? So we talked a lot about antibiotic exposures today and C. diff risks. We also know over the age of 65, you are really at high risk and having high mortality and morbidity when you get C. difficile infection. Immunosuppressed patients have high risk for C. diff infection as well as pregnant females. But we also have to start focusing on isolation and hand hygiene as well as environmental cleaning. So I'm going to focus more on that today here. And also gastric acid suppression. So there's a lot of studies that's showing us now that if you have C. diff patient, unnecessary PPI puts your patient at high risk for C. diff or continuous recurrent C. diff. So eliminating that as well. So just a quick reminder, if you do have C. diff infection, with the new guidelines, metronidazole is no longer the first line regimen. It's oral vancomycin is your first line regimen. And you could also use fidaxomicin. Of course, it's more expensive, but it's just as efficacy. But oral vancomycin is your ideal drug. So this study was published in 2015 where they looked at risk of organism acquisition from prior room occupants. So they looked at, okay, what happens when you have a patient in a room with all these different organisms, MRSA, VRE, ESBL, C. diff. And when they leave and you have a new patient going to that room, what is the risk of the new patient getting the infection, these resistant organisms? So when they did this pool study, they looked at over 4,000 patients, 7 different studies. They know the data showed that if you have gram-positive bacteria, about 2.6 odds of having the newer patient getting that inflammation, gram-negative about 1.8 odds of getting the infection. So here, this graph nicely shows pretty similar, looking at all the different organisms and increased risk of acquisition if you had a patient prior with these infections. So clearly, we are in our environment transmitting these infections to our patients that are coming into our hospital setting. So how do we work on reducing this risk? So how many of you guys are currently working on C. diff reduction in your hospitals and working on implementing process? Hands? So a lot of people are working on that. Good. So in our healthcare system, we know we need to use sporicidal agents to kill C. diff spores. So ideally, what we do, our environmental EVS personnel, they used to take bleach, mix it with water, and clean those rooms. That's pretty cumbersome process for during your workday to mix, clean. So this study in 2019, what they looked at was, can we effectively use bleach spray to reduce C. diff transmission? And what they looked at so they looked at C. diff rooms and non-C. diff rooms. So they sampled about 51 rooms that were cleaned with usual products that is not sporicidal. And they found, when they cultured, about 24% of the time, they isolated C. difficile organism. So even though we're using our ammonium-based disinfectant properly, when they cultured those rooms in high-touch surfaces, 24% in this study found C. difficile spore. But when they used this bleach spray, and the nice thing about this bleach spray is that they educated the EVS personnel, and if you had a room that did not have a C. diff patient, you spray the bleach, and either you could wipe it down or let it dry. But if you had a patient with C. difficile, you have to terminally clean the room, and then you spray the bleach and either you wipe it down or let it stay for 2 to 3 minutes. So by doing this process from our EVS staff, in this study, they were able to reduce the C. diff spore in the room up to 5%. So significant reduction from 24 to 5%. So that's something for us to consider. But not only did it reduce C. diff spores, but it was also able to reduce MRSA as well in this study. So, if you guys are struggling to clean all our rooms after discharge, I don't have any commercial sponsoring from this company, but I think using a bleach spray product might be an ideal thing to do. And we're actually considering doing that as well. So modern technologies to kind of see how clean our rooms are in the hospital. Anybody here use fluorescent lighting in their rooms to see how clean your rooms are clean on discharge? Anybody do ATPase testing? Great. So fluorescent lighting technique. So it's black light. So in this picture, if you look here, they put the fluorescent marker, and these are for audits for your environmental personnel. So you put the black light marker, fluorescent light markers on high-touch surfaces, and then after the environmental staff have cleaned your room, you use the black lighting to see that all those surfaces get cleaned appropriately. So you have before and after. Fluorescent gels, they come in gel, powder. You mark the high-touch surfaces. It's very cheap. So I'll talk about ATPase. It's more expensive, so this is much cheaper to implement. And also, this is a good way for you to do audits and give feedback to your environmental staff to say, how are we doing on all our discharge rooms, and how are we cleaning these high-touch surfaces? And we started implementing that in our hospital, I would say about 3 years ago. So it's been very effective. And if you also look at ATPase, so ATPase, you take a swab, you swab the high-touch surface, then you put it in this reagent, and then you put it in a luminometer to see the results. So if your results are low light units, that means you have low bioburden, low bacterial load. If it's high, either you have high bacterial load or you have lots of debris. Either way, that surface is not cleaned that well if it's high. So what we have utilized this technique is for our C. diff patient's room. So when we have a C. diff patient and they're getting discharged, what we do is those rooms we use ATPase to monitor the appropriate cleanliness for our rooms. And we use the black light markers, which are fluorescent technique, in other rooms that are not C. diff patients. because of the cost, because ATPase, each of those tubes cost about, I believe, about $2 or so. So high touch surfaces, so bed rail, nurse call button, infusion pump, floor sink, rails, call buttons, these are all high touch surfaces. If you look at CDC, they actually give you a list of all the high touch surfaces as well. So just to recap, hospital-acquired infection in 2011, there was about 722,000 cases. About 1 in 25 patients in hospital get a hospital-acquired infection. And $33 billion or more we spend on hospital-acquired infection nationally. So also, have you guys wondered if you have a patient that has C. diff infection, what is the chance of percent their skin and the environment actually has C. diff spores? So this study actually did that. So they looked at patients with C. diff, and they looked at what is the percent you had C. diff contamination. Patients had up to 60% skin contaminations with C. diff spore, and in the environment was up to 37%. At the end of treatment, they still had about 32% skin contamination and environmental about 14%. So there's a lot of bacterial C. diff spore burden, not only on the environment and the patient as well. So what did we do? We in our Creighton University came up with the process, and I want to also share this. This is from UCSF. UCSF, they have done a really good job of having a bundle for C. diff. So when a patient comes in, if you're worried about C. diff, not only do they have the therapy you need to do, how to clean the room, they have all this is a bundle approach. And I think that is the next step for all of us to do a bundle approach for all our C. diff patients. But what I really like about their approach here is, what do you do with the patients that are in your hospital that are C. diff positive? They're having 10 to 15 stools a day, and now their stool is, their diarrhea is finally resolving, and their stool is formed. So, but the patient is still there because they have another chronic condition, and they're there for another 10 to 15 days. What do we do with those patients? So what we should do with those patients is, ideally, when your stool is formed, what we do at CMC Creighton is after 48 hours of your stool being formed, you can transition the patient to a clean room, which is pretty similar to what they have at UCSF as well. They move the patient with C. diff infection to a clean room. They educate the family members the importance of a clean environment, because you can find, obviously, in the room the patient was initially in, lots of C. diff spores. And then the nurse puts in a request to transfer the patient to a clean room within 24 hours once the stool is formed. Before the patient is transferred, the patient is bathed and cleaned before the patient goes into the clean room, before we take the patient out of isolation. By doing this process, and this is because the prior study, because we are contaminated, the room and the patient is contaminated with C. diff spores. If you cannot move the patient once their stool is formed, you keep them in isolation for the rest of their stay. However, you make sure you clean that room now with bleach products, sporicidal products. So I could so in our institution, our C. diff rates, we were averaging what our Nebraska average was. In 2017, we had about our SIR rate is 0.8. So we had a lot of opportunity to reduce our C. diff rate. So what did we do? It was a collaborative effort. Everybody was on the table. We have environmental service personnel. We have our IPs, our stewardship. We all work together to try to reduce this. So in this year, we have reduced our C. diff rate to 0.59% SIR rate. And overall, we have our cases today is about 30 cases less than compared to the prior year. by implementing a bundle. We haven't actually made the bundle approach yet, but it is a bundle approach now. We have to put it together. So it definitely it has to be a team approach, everybody working together. Another approach we have taken is every morning when we come in, when I come into work, myself, Jen Anton, our antimicrobial stewardship pharmacist, and our IP staff, we get an email list of all the C. diff orders that have been ordered in our hospital. And we actually go through each of those cases and say, do we really need C. diff in this order in this patient, or is it inappropriately ordered as well? Because a lot of times, you guys all know, patients are on laxatives and they're getting tube feeds, and there's other reasons for having watery stool. So, and then we make, it's like antibiotic stewardship, but the C. diff stewardship. We're making calls to the teams and asking, do you really need this C. diff test? Because as you guys all know, over 20 to 50% of patients when you're in long-term care or when you're older are colonized with C. diff as well. So is it truly infection, or are they colonized? So I think it's really important in our bundle approach to also tackle when the tests are truly needed as well. So understanding our nurses' workflow, batching care, and potential opportunity for transmission of infection. So this study, it's really nice. It was just published in 2019 in January. So where they looked at our nursing staff, and this is they just focused on nursing staff, but I also want you guys to think about this is not just for nursing staff, this is also for all healthcare workers that are entering patients' room when they're in isolation versus non-isolation, okay? So for example, this nurse number 2, she enters the room, she does hand hygiene, she comes in, so dirty environment is red, so dirty areas are red, environment is blue, hand hygiene is with this H. So what she's doing is when she comes in, she does hand hygiene, she puts the light on, touches the patient pump. Before she sees the patient, she does hand hygiene, puts gloves on, takes care of the patient. Then she goes to the dirty area, she looks at the Foley bag, and then does hand hygiene again, and then does some more environmental and leaves the room. So what they notice is when a patient is in a non-isolation room, what nurses are doing is they're doing their task in a smaller batches. So they're doing 1 to 2 tasks at shorter duration, 10 minutes or so. So they're doing hand hygiene much better. But what happens when you enter a C. difficile room? They're spending up to 25 to 40 minutes in these rooms, and they're doing more tasks, 10 to 12 tasks during this time. But are we following hand hygiene during this? So as you could see, when she did hand hygiene on entry, again in here, on exit, but there's a lot of dirty surfaces and environment that nursing staff is touching, and she's not doing any hand hygiene between the environmental area and the patient. There's a lot of break in hand hygiene. And this is also for all healthcare workers in a patient's room when you are in isolation. So we tend to batch our tasks and a break in hand hygiene, which leads to increase in transmission of our infection, and it's also a bad patient care. So we need to start thinking about kind of focusing more on this, because I really like this study, how they did this. So more on also looking at how does the providers are in the rooms, and food service personnel, so kind of learn more about that as well. So future studies in this area. So you could reduce antibiotic exposure in lots of different disease process. But one thing that we see always is a lot of UTI treatments with antibiotics. So impact of C. diff rates with reduction in treatment for asymptomatic bacteriuria. So especially in our nursing home long-term care facilities, 11% of our patients on every single day are on antibiotics. 1 to 3 of these antibiotics are prescribed for UTI. So I just want to focus on just UTI, asymptomatic bacteria, 1/3. And out of these prescriptions, half of these prescriptions are for the wrong drug, wrong duration, and the wrong dose. we have lots of opportunity. So how does that relate to decrease in C. diff infection? So they did a study at Massachusetts Department of Public Health, where they worked with 16 nursing home facilities. They did intense teaching for all the healthcare workers at each of those facilities, and in-person training through the health department. And 1 year later, they noticed not only 28% decrease in unnecessary urine culture, 37% decrease in antibiotic given for asymptomatic bacteriuria. Only time we should be giving in asymptomatic bacteria is pregnant females, or if you're having urological procedure. So other times we should not be giving. So 37% decrease, but the biggest impact is 47% reduction in C. diff infection in these 16 nursing home facilities. So it does work. Similar study was done again in Canada, in Ontario, where they wanted to reduce unnecessary urine culture and antibiotic overprescribing in long-term care, and they did before and after analysis. Again, they had multiple different strategies how to reduce urine cultures. And one of the big things that they did was not only teaching, but having champions. So champions and leaders to make sure that somebody's there to speak about and help take care of when not to treat for not needed for UTI and antibiotics. So things that they focused on: urine culture only when residents have indicated clinical signs and symptoms. Urine specimen should be collected midstream or straight cap. Prescribe antibiotics only when it's clinically indicated. So five simple things that they did. Number 4 was do not use urine dipstick anymore. And they went to urine analysis. Cease urine culture screening on admission and annually. There's no reason we should be doing urine culture for screening. By doing that, again, if you look at here, baseline urine culture, after the intervention, significant reduction. Again, if you look at antibiotic prescription, baseline, a lot of antimicrobial prescription, intervention, significant reduction. So it does work. So, and I think if you look at C. diff prescription, outpatient antibiotics, if we can reduce outpatient antibiotic use by about 17%, nationally we could reduce C. diff rates by 10%. So that could make a huge impact. So in conclusion, what I wanted you guys to take away is, in order to combat C. diff, it's not just antibiotic stewardship. It has to be a team effort. We need environmental cleaning. We need working with hand hygiene, isolation process. So it needs to be a team effort and a bundle approach to get good patient care and quality of care.